everyone. Welcome to the Trial Site News podcast interview series. We have a return guest, Dr. Jeffrey Klausner, who is an infectious disease specialist, a professor of epidemiology. He came on here in his last episode and discussed naturally acquired immunity to COVID-19, which was a really fascinating episode. So if you haven't watched it yet, please do. But thank you so much, Dr. Klausner, for joining us from California.
Yes, very happy to be here. Thank you.
Absolutely. Now, today we're not talking about anything COVID related. We're talking about another really important topic, which is increasing rates of syphilis, which is a sexually transmitted disease. But I thought, let's refresh everybody's memory because everybody's just talking about COVID. So maybe can you start out by just telling us some basics about syphilis, how you get it, maybe the stages, who's most at risk?
Absolutely. Well, syphilis is one of the oldest infections of mankind. It is caused by a bacteria. The bacteria is named Treponema pallidum, and that bacteria is most commonly spread through sexual contact, but can also be spread just by direct skin-to-skin contact, such as shaking someone's hand, or nurses used to get syphilis if they were, touching or taking care of patients who had active lesions. But, that said, by far, 99.9% of all syphilis cases are spread sexually. Although now what's been problematic is there has been an increase of maternal to child spread of syphilis, what we call congenital syphilis. And syphilis typically will be acquired from contact with someone else who has a active infectious lesion. So they will have some kind of sore, what we call a chancre, and that can be inside the mouth, that can be in the anus or rectum, that can be in the vagina. And the tricky thing is that lesion is often painless. So people will have this inside their body and not know they have it. And that's how one characteristic that makes it very easily spread. So it can be spread essentially asymptomatically. And then the person will acquire it. And then the person who acquires syphilis, typically about 2 to 3 weeks later, they may now develop a sore or a chancre. And again, that could be inside the mouth, could be inside the vagina, could be in the anus. If it's a male, they may have that sore or chancre on the penis. And typically, when someone sees a sore or chancre on the penis, they'll get concerned and they'll start worrying about it. They may go Google about it. And typically with syphilis, that goes away in a week or two. And that's called the first stage of syphilis. Then there is a period of quiescence, or we call latency. And then about 2 to 3 months later, there'll be the secondary stage. And that secondary stage will be characterized by a rash on the skin, maybe flat red spots on the chest or back, or the arms. May have a fever, may have swollen glands, particularly glands under the arms or around the groin. And often people will seek medical care for this, rash and fever and not feeling well. However, if they don't tell their clinician, or commonly the clinician doesn't ask if they're sexually active, it often gets misdiagnosed. So it's very important that physicians and clinicians do take a sexual history whenever they see someone who may have an infection, and ask them if they're sexually active, if they've had any new partners recently. And then it's also expected that if a patient, is coming forward, with some clinical findings, that they do, tell their provider about their sexual activity. So we don't believe in the don't ask, don't tell in this area. And then if it goes untreated, then that rash and fever and swollen glands will go away after about maybe a couple of weeks, and then they'll go into a prolonged latent phase. And about 75% of people then will never have any future problems, but about 25% of people, if it goes untreated, can have severe complications 10 to 20 years later. And those severe complications can be syphilis of the brain, and syphilis of the brain can be associated with dementia, change in personality. So there was a lot of, speculation that famous people in the 17 and 1800s may have had syphilitic brain disease, and that was what caused their, dementia or decline. Chronic syphilis infection can also cause severe disease of large blood vessels on the heart. So people who have swollen aorta or abnormalities with their heart valves, often doctors will test for syphilis in that situation. And then the third kind of type of long-term syphilis can be what we call syphilitic gumma, or these inflammatory lesions that can occur anywhere in the body. And these inflammatory swollen lesions can cause intestinal obstruction, can cause pain, and those are internal typically, and they'll only be identified in a CAT scan. The good thing about syphilis, though, it's very easily detected by a simple blood test. So the CDC recommends all sexually active individuals get tested for syphilis with a simple blood test. And then when people go to their doctor and get their blood drawn, they should ask them if they're sexually active, with multiple partners. Are you testing me for syphilis? I want a syphilis test today. And then if that test is positive, syphilis is easily treatable with penicillin. So penicillin became available in 1943, and now we are, 57, 78 years later, and syphilis is still highly susceptible to penicillin, which is pretty amazing. So there's no resistance to syphilis in terms of penicillin therapy. However, penicillin suddenly became very expensive, hard to get. So there have been sometimes delays in treatment, and we think that contributes to this rise in syphilis, is that people are not getting the penicillin therapy they need. There are alternatives to syphilis. In non-pregnant individuals, can be treated with a common antibiotic called doxycycline.
Yeah.
Typically, when someone does test positive for syphilis, the positive test is reported to the local health department. So people can expect to get a phone call or a letter or even a visit from the local health department, and that's normal. So expect that. And as part of that visit, the health department wants to make sure that the case was treated. They were treated effectively with the right medicine for the right amount of time. And additionally, if there's been any recent sex partners, that those partners have been notified so they can get treated or tested as well. A good thing about syphilis also is if someone has been exposed, they basically have 90 days to get treated before they will test positive or develop syphilis. So you can actually give preventative syphilis therapy. So when I was the STD chief at the health department in San Francisco, we spent a lot of effort making sure people who were exposed got this preventive treatment.
And could you talk a little bit about congenital syphilis? What would happen there, and how would you treat that to make sure, because the baby could have some serious side effects if it's not detected and treated. Is that correct?
Yeah, absolutely. Congenital syphilis can be devastating. It's associated with stillbirth. It's associated with severe neurologic developmental delay. 50% of congenital syphilis cases may result in stillbirth or early infant death. So it's really something that we need to take seriously. And unfortunately, it's gone up by over, I think, 600 to 700% in the past 10 years. So 10 years ago, the United States had, by WHO definitions, eliminated congenital syphilis from the United States. It was at such a low rate that it was deemed of no longer public health significance. But now, over the past 10 years, we have very high rates, and higher in particular parts of the country, particularly the Southeast, Texas, parts of California. And as we've been studying it, we've learned it's really a failure of our medical and public health systems, is that pregnant women either are not tested. If they're tested and they're positive, they're not followed up in a timely way for treatment. And it's really something that should not be occurring in the United States. So to prevent it, every pregnant woman should be tested for syphilis at their first prenatal visit, and then typically in their third trimester as well. And in some states like California now, the law requires that women at increased risk have a third test, and that test must be documented before they can be released from the hospital. So some women actually may undergo 3 tests uh, during their prenatal care, just to really make sure that they have been infected. The good news again, though, is if a woman is identified with syphilis, particularly early in their pregnancy, a single shot of penicillin treats both the mother and the fetus. So a single shot of penicillin be highly effective at preventing congenital syphilis. But it takes this system, right? It takes a system of testing and of treatment.
Yeah.
And the United States, our healthcare is so disjointed, it's not very good at any kind of system level approach. Historically, public health departments used to be resourced at the local level with public health nurses, with investigators, contact tracers, people whose job it was to follow up on every positive syphilis test. But over the past 10 to 20 years, those services have really eroded. And that's obviously why, we're in such a bad COVID situation right now as well.
So I was reading about the rates, and they're pretty alarming. Let's see, 2019, the rates of syphilis were double the case count of 5 years prior. And then I was reading this in 1999, like you mentioned, they were basically thinking about eradicating syphilis. And so what happened? Why all of, after that, that's like, wow, to go from thinking that you're going to get rid of this to all of a sudden increasing rates. What happened?
Yeah, so when I took over that section in the San Francisco Department of Public Health in 1998, there actually were 0 cases of syphilis, 0 in the city and county of San Francisco.
Wow.
And then in 1999, the CDC said, okay, we're at the lowest historical number of cases of syphilis. Let's eliminate syphilis. And this was actually the 5th time that the CDC had launched the national syphilis elimination effort. And they got some additional funding from Congress. And there were, a bunch of cities that were mobilizing. There was a lot of, health communications. There was a lot of partnerships going on. And because syphilis only exists in humans, there's no animal reservoir. There's no, other place where syphilis exists. So kind of like smallpox, if you can eliminate syphilis from humans, you can potentially eradicate it from the human race. And we had an easy blood test that was, 10 cents for a blood test. We had lots of penicillin. So all the tools were there. And what really happened were twofold. One was the internet. And the internet made it very easy for people to meet new sex partners. And also in late 1999, we finally had treatments for HIV. And without treatment for HIV, people were scared to death of HIV and AIDS, appropriately so at the time.
Yeah.
And, people who normally would have multiple sex partners or engage in higher risk sex or go to sex clubs or bathhouses, they were not doing those things in the mid 1990s. But when treatments became available, that kind of behavior started to increase. And the internet was making it very easy for people at higher risk to connect to each other. So actually in 1999, I discovered an outbreak of syphilis related to AOL. I don't know if people remember AOL.
AOL chat, yeah.
Yeah, AOL had chat rooms and had meeting rooms, and these meeting rooms would only allow 23 people maximum to be in a meeting room, but these meeting rooms would pop up in cities anywhere. And these meeting rooms enabled people to find a sex partner and have a hookup in less than 15 minutes. And we used to say in San Francisco, you couldn't get a pizza in 15 minutes, but you could find a sex partner. And we told the CDC about these increases related to, these different factors. And unfortunately, Congress did not allocate any additional resources. So we start to see the slow increase from 1999 to basically 2004. And the 5 years of congressional funding were exhausted by 2004. We did not eliminate syphilis, and syphilis came back. And since 2004, has been steadily increasing. And now what's a particular concern, it's become more common in women and women of reproductive age in particular. So that's why we're seeing more cases of syphilis among newborns or congenital syphilis. And we've really, lost control of our ability to, prevent and manage syphilis at the population level.
That's really interesting. An effect of the internet. I guess it has both good and bad. I was also reading about it, and you talked about the funding for public health things, and some people say, well, public health is more like responding to something when it's already gets bad versus prevention. And this one woman who worked at a public health department was saying they had to pick and choose which syphilis cases they could do contact tracing for, because they just didn't have the funding or the manpower. So how do you fix that?
Right. I mean, there's something in public health called Brown's Law, which says when the cases go up, the funding then follows, and when the cases go down, the funding disappears. So, the way to, fix that really is for legislatures to, have a, fixed public health budget based on the population size. So, in the state of California with 40 million, residents, there should be a $4 billion public health program. And that, $4 billion public health program should be matched to the state with resources, given down to the county based on the county population. And, there should be some minimum, public health activity that assures, the safety of the water, the safety of the air, the, ability to do disease control and prevention. But that doesn't exist. And there's really, no one advocating for, kind of a minimum, package for public health. I mean, we're hopeful that with the, COVID-19 pandemic, there'd be this resurgence and interest in funding public health. But I mean, it's really been kind of one-time funds that, have come in, but all those funds are going to expire in a couple of years, and we will be back in the same place with limited resources and an inability to respond to different epidemics. I mean, things like sexually transmitted infections, whether it be syphilis, HIV, herpes, chlamydia, gonorrhea, trichomoniasis, human papillomavirus, all these things require, ongoing resources and ongoing programs. The problem, really is that because these different diseases are, carry a lot of stigma, you don't see many advocates, saying, I got gonorrhea, I demand more money for gonorrhea treatment.
Right.
Or,
Sure.
I have syphilis, so let's make sure we're funding syphilis adequately.
Yeah. I wanted to ask you, when you talked about how, when the drugs and the treatment for HIV evolved, and there was less fear about getting it, and they've been really successful. What are you seeing increasing rates of HIV now, or any of the other sexually transmitted diseases?
Yeah, so the sexually transmitted infections overall have increased, absolutely. So there's been increases in chlamydia, increases in gonorrhea, increases in syphilis in the general population. HIV remains, unacceptably high and steady, somewhere between, 30 and 40,000 cases a year. And, these new cases are in, underserved population, minority populations that unfortunately, private funders and government doesn't really care about, and they don't make investments. And the researchers, including myself, have talked more about, well, there's the social determinants, right? So there's the the poverty, the lack of education, the mental health issues, the substance use, different crowded housing, lack of economic opportunity. All these things create these syndemics that come together and put people at risk. And until we could really address some of these social factors and drivers, I mean, we're going to be stuck with these consequences. I mean, maybe the fact they call these diseases social diseases 100 to 150 years ago were because then they recognize as well there were social determinants of these diseases that put people at increased risk.
Yeah, absolutely. That's really getting to the heart and soul of prevention, which we don't really do a good job with, but maybe we will in the future. One last question. I actually was reading your bio, and it mentioned that you have an interest in using technology to address some of these issues. I do too. That's what, before my current job, I used to manage an evidence base for technological interventions for chronic illnesses. And it's really, you can reach a lot of people that way. And when you mentioned how sort of the boom of the internet brought back some of these diseases, I wonder, is there a way to then use technology in some way to combat it?
Yeah, absolutely. So, I mean, this has been a interest of mine for over 30 years. So, in response to that internet-associated outbreak on AOL, we actually founded a nonprofit company now, which is called Youth Technology Health, or YTH. And with this company, we created online services where people could basically self-order a syphilis test. They could print out a syphilis test request form, take it to a laboratory, and without having to see a physician, without having to see a nurse or anyone, just basically get a syphilis test on their own and get the result delivered, right to them. We've seen, this big growth now of home-based STI testing companies, where you can go online to mylabbox.com. You can order a cute little box that comes, in brown paper to your home, and you could do different, urine tests, swab tests, finger prick tests for different STIs. We also had a text message service, which was called Sex Info, and basically the health department would promote, this text message service, and people could use the service and find out, where to get tested, where to get treated, how to, talk to a partner about condom use, where to go if they found out that they were pregnant. So we know, a lot of people, because these issues of, concerns with privacy and confidentiality, want to use, these kind of anonymous resources. And also, technologically, I continue to work on these kind of rapid, very inexpensive, what we call lateral flow tests. So basically, with a saliva specimen or a finger prick blood specimen, you can in your own home, know if you tested positive for syphilis or for other sexually transmitted infections. So, I mean, obviously we've seen this huge growth in the COVID industry around this currently, but you haven't seen it for STIs.
Right.
And it just really reflects our continued stigmatization of STIs, reflects our lack of creativity, I think, and reflects what the priority of funders are. I mean, I really think people would use them if they were available, but we need to develop these technological tools for people. We also created websites for information and education, a lot of sexual health videos, different kind of apps people could use to look at their risk score, so based on their number of partners or their sex of partners or their age, were they at high risk, were they at medium risk, were they at low risk? And all these things helped, and a lot of them were small demonstration projects, but few of them really went to scale. And that's the challenge in public health, is how to get things to scale to really move the needle.
Well, it would seem like a good idea if everyone could have those strips just, at home. and
Yeah,
just to check.
absolutely. Right. I mean,
Yeah,
you have a urine pregnancy test. You
yeah,
have now, like home, yeast test. Now you have home COVID test.
right.
Why don't we have, more easy, accessible home tests for STIs?
Right, right. Well, maybe we will now that they see that these rates are growing and out of control. Um, Anyways, Dr. Klausner, it's always a pleasure to chat with you. Thanks so much for all for educating us all about syphilis. Hope to see you back on Trial Site News again with another topic related to infectious disease or whatnot.
All right,
And
absolutely.
yeah, and to everybody who tuned in, thanks so much for listening and hope to see you guys next time too.
All right, take care.
You
Bye-bye.
too. Bye-bye.